if you look at the randomized control trials, we know that in our good old days, we were taught that digoxin and diuretics are the only therapies which are meant for treating heart failure patient. But none of these therapies impacted mortality of heart failure. So what came as a foundational therapy or mortality reducing agents, where in this fashion, if you look at the ACE inhibitors and the beta blockers and MRAs, they all have been consistently shown to reduce mortality of heart failure patients, and beta blockers, which are largely negative inotropic drugs, should be used with a lot of caution and titration, because an over-enthusiastic use of beta blockers can always worsen or precipitate acute decompensated heart failure. So therefore, it is an art form to start beta blockers with a very small dose and then escalating them to the highest tolerated dose so as to reduce mortality of heart failure patient. So such is the journey of randomized trials, and it goes on further where there was a role of the devices like the ICDs in prevention of sudden cardiac death, both primary as well as secondary, and of course the role of cardiac resynchronization therapy, as was in MEDIT CRT trial, that patients with underlying left bundle branch block or QRS in excess of 140 milliseconds would actually benefit by giving them a CRT device, and of course a combo where the sudden cardiac death could be prevented because of heart failure. There have been trials on the surgical front also, not with much success, like a stitch, and trials with artificial heart, that is LVAD, the HeartMate 2. And this is the journey of the randomized trials of last 3 decades in heart failure until a landmark drug which was tested in the paradigm heart failure trial, and you know what I'm talking about, is actually the ARNI, which is a combination of sacubitril and valsartan as an ARB. And this drug was tested in heart failure patients with reduced ejection fraction less than 40%, with the primary endpoint of CV mortality in her first hospitalization for heart failure. And it was a randomized double-blind trial where in the run-in period, the patients were randomized on 10 milligram of enalapril, which is an established heart failure therapy, versus this ARNI, which is a combination of sacubitril and valsartan in the dose of 200 milligram twice a day. The trial ran for 27 months of median period. The patients who had ejection eGFR of less than 30 ml or had a history of angioedema, or they having symptomatic hypotension, or a requirement for treatment, both ACE inhibitor ARB or potassiums were high, were the candidates which excluded from the trial, but those who were included, their anti-proBNPs as a diagnostic tool were in excess of 140 and more than 100 respectively, were included in this trial. And what was seen at the end of trial, that this was the largest mortality morbidity trial in patients of HFrEF, most geographically diverse trial in patients of HFrEF, and most racially diverse heart failure trial, because in this trial, a very vast majority of patients were recruited from Asia and in India in particular. So what happened at the end of the trial was there was a 20% cardiovascular death reduction, 20% heart failure hospitalization reduction, 16% overall mortality reduction, and sudden cardiac death and heart failure death both were significantly reduced as compared to the enalapril and conventional heart failure therapy. And if you look at the number needed to treat for mortality reduction compared to the various other agents, in case of ARNI, it was 20% relative reduction of mortality, 32 number needed treated, and there was a 21% reduction in the heart failure hospitalization. So this was a revolution which happened about 6 years or 8 years ago, and the benefits were evident in the sense that after 30 days treatment of ARNI, a significant improvement of NYHA class was found in close to 1/3 patients, and by at least one NYHA class. And there were largest number of patients in NYHA class 1 at the end of treatment as compared to the other therapies. It was clearly superior to ACE inhibitor across the subgroup of chronic heart failure patients, going by the age, ejection fraction, eGFR, systolic blood pressure, and anti-proBNP values. And if you look at the Asian cohort, across all the parameters of this trial, the primary endpoint and the secondary endpoint, there was a remarkable treatment benefit. The ARNI was better than enalapril across the board.